So, eminent and most respected chairperson, Professor Behel, senior faculty members, colleagues, ladies and gentlemen, my job today is to discuss with you all overcoming challenges in PCI of anomalous coronary arteries. As we go on increasing our volumes, it becomes, they don't become such a rare scenario that every once a week or once a month we will get a coronary artery that is anomalous in its origin, anomalous in its course, and we find it tough to overcome these challenges. Before we move forward, let's step back a bit and try to understand the basic. Most of us would be knowing it, but it's always good to refresh our memories. Go back to the embryological development of the coronary arteries because they are very important in understanding the origin and the course of the coronary arteries. So there are three essential elements in the embryological origin of coronary arteries. One are the sinusoids that develop in almost the first week of intrauterine life, and they form, most of them are absorbed in the later phase of intrauterine development, but few remain as part of a microcirculation of coronary arteries, and they fuse with something that are called as the stems. These stems are the body of coronary arteries, and there are three stems for circumflex, LAD, and RCA, and these stems essentially develop in the interventricular or the atrioventricular groove, and therefore they fuse with the sinusoids which form the microcirculation, and the stems themselves then fuse with the two bulbs, one on the left side, one on the right side, developing from the right posterior and the left posterior quadrant of the bulbochordus even before there is a division of aorta and pulmonary artery. So they kind of form this infrastructure, and based upon this infrastructure, a lot of interesting observations happen. For example, if there is non-remission of the sinusoids, then you will get something as a coronary cameral fistulas, and the course of the various arteries are also dependent upon this embryological principles and basic. So there are a lot of anomalies that can happen. For example, the anomalies of origin, left or the right coronary artery can take its origin from the pulmonary artery, and that happens because the buds develop before the bifurcation of bulbous cordus into aorta and pulmonary artery. So these buds can move to the pulmonary artery part, and then you can have a left or the right origin of coronary artery arising from the pulmonary artery. We can have the anomalies of the course, myocardial bridging or coronary aneurysm, and we can have the anomalies of the termination, the atrioventricular fistulas or the coronary cameral fistulas. However, for the point of our discussion today, as we move forward, we will restrict our conversation to anomalous aortic origin of coronary arteries, left arising from right and right arising from left. Okay, so we'll come back to this again in the concluding slide, but please remember that the epicardial arteries, whenever we are describing the course, we have to remember that the epicardial arteries, because they are developing in separate stems in AV and interventricular group, can never cross each other anatomically and embryologically. Whenever we are getting confused in the view, always remember RAO, RAO, RAO. RAO is the angiographic views that tells you sometimes about the origin and almost always about the course of the coronary arteries. And the two biggest challenges during PCI are guide engagement and guide support. So let's take the example from circumflex from right sinus. The first impression, the first hint that you get is when you see an abnormally long left main. Now sometimes we are confused that this particular branch coming out here is a rudimentary circumflex or a diagonal. We are confused that way. It may be a rudimentary diagonal or a long left main. Okay, so next view, remember, is RAO. Whenever we are confused, view is always RAO. I apologize for the short injection. We cannot see the coronary sinus, but whenever you see left circulation in the RAO view, you have coronary sinus which would be coming here. The circumflex would be occupying this portion. So if you have a bald coronary sinus segment, therefore the circumflex is not there. You can have three possibilities. You may have a very short left main and a selective engagement of the LAD. You can have a twin ostium of LAD and circumflex, or you can have an anomalous circumflex from the right coronary artery. So if we, after disengagement and non-selective injections, you have ruled out twin ostiums or a short left main, what you are left with is an anomalous circumflex from the right sinus. You engage the right sinus, and most of the time you will not pick it because of the deep engagement of the guiding or the diagnostic catheter into RCA ostium. Even if the circumflex is taking origin from the right coronary artery, it is from a very proximal segments, and deep engagements would not help you in diagnosing that. What you have to do is pull out your catheter, do a clockwise turn, try to force the catheter to look backwards, and then you can engage selectively the anomalous circumflex coming out of the right sinus. So let's then ask you, what can be various possible courses of this anomalous circumflex coming out of right sinus? So whenever we say possible complexes, we have multiple things cropping in our mind. But remember, always remember from embryology, the stem of the circumflex is here. The arteries cannot cross each other. So there's no way from the circumflex originating in the right sinus to follow any path except the retroaortic course. So the only path that the anomalous circumflex originating from right sinus can take is the retroaortic course to come in the left AV groove, and there's no way it can come forward, because then it would have to cross the left main and the LAD territory. How do you diagnose it? Confirm it. Again, RAO view. You take a look at the RAO view. You look here in this cartoon, a very poor cartoon, I'm sorry. This is the aorta here, and in the RAO view, you have pulmonary artery somewhere here. In the angiography, pulmonary artery is somewhere here. In normal RAO view, this green artery represents the RCA falling straight with the RV branch. The circumflex will actually move a little backwards, take a rotation curve here, make a curve here, and come back in the left AV groove, which in RAO view would tend to run almost parallel to the RCA, because the right AV groove and the left AV groove are almost superimposed in the RAO view. So circumflex from right sinus will always take a retroaortic course. So this is an inferior volume myocardial infarction. Notice here, long left main, no artery in the RAO view, in the coronary sinus plane. You can't see anything in the deep right injections. What you do is that you pull back your guide, try to take an injection, and now what you see here is a faint thrombus, and gives you some hint that this anomalous circumflex is somewhat 100% occluded in its part. You can change your guide to an emplatz, point it towards backwards via the anomalous circumflex, thrombus section, stenting, and a standard procedure of PCI. Now let's come to the RCA from left sinus. The right coronary artery and left sinus, if you see in this plane, will almost always take its origin from the anterior and superior to the origin of the left main ostium. RCA from left sinus will almost always arise anterior superior to the ostium of the left main. This is something that we have to remember. What are the courses that it can take? Now, like circumflex, RCA is also a very disciplined artery even when it is anomalous. It will almost always take an interarterial course. It will flow between, like you see this cartoon here, it will course between the pulmonary artery and the aorta, come to the right side and enter the right AV groove. So RCA arising from left sinus usually, and I want you to replace this term usually with almost always, will have an interarterial course. But it's not so bad with RCA. Many a times we have this in incidental findings. If there is no angina, of course with acute myocardial infarction you will have to handle it. What we are talking about is a stable setting when you see anomalous origin of the RCA in your angiogram from left sinus. It is mostly non-malignant. There are no symptoms, there are no ischemia, and nothing is to be done about it. But sometimes, rarely, it can be malignant when it produces angina on exertion, syncope on exertion, ventricular tachycardias, large area of ischemia on thallium, and sometimes, very rarely, as a sudden cardiac death. And it is malignant. When it is malignant, the various contributing factors are slit like ostium, compression of the artery, proximal segment of the artery between pulmonary artery and aorta, intramyocardial bridges, angulated origin, and associated CAD. And when it is malignant, and if you are able to demonstrate the malignancy here, then there is nothing, no other option, no angioplasty. Only option is a surgery, either transplantation of the artery to the normal segment or simple ligation and bypass. The two biggest challenges in anomalous RCA PCI from left sinus are guide engagement and guide support. In guide engagement, there are special guides which point superiorly and anteriorly, like Leah, CHAM, but they are not usually available in most of the cath labs. You can actually modify your Judkins and implants to point forwards, and we will discuss that. And what you can do sometimes in a very difficult situation, you can engage it with a diagnostic catheter, pass an 0.014 normal coronary guide wire, and then exchange your diagnostic with your guiding catheter. So there are various catheters that are described, but most are not available. Mostly you are able to do it with implants of various sizes, trying to push the implants up and superiorly. But if you can't do it in rare scenario, and we end up doing it once or twice a year, what you do is you take your normal implants or normal Judkins catheter, and you give a 90 degrees off course turn, looking forwards. The catheter will not turn and it will not take the shape. What you really have to do is dip it in hot boiling water, give this curve, put it in cold water, again put it in hot water, give a curve which is off course 90 degrees forward bent here, and by dipping it in boiling water, you make the catheter more malleable. You are able to do that. You are able to give that curve and engage the superiorly and anteriorly looking coronary arteries. So above, it's an implant engaging the left system. If you have to engage the superior anterior, you have to clockwise rotate it and push it so that it goes forward and engages. If you can't do it, you can give an off-course curve, modify the catheter in your cath lab, and then you can do it. This is the inferior wall myocardial infarction. This time RCA is missing. You try everything, it's not missing. Finally, you can engage it with the large size implants. And there was a lesion here. Sorry, I did not show you there. And you treated this lesion with an angioplasty. Now, this was the guide support, or guide engagement. What about guide support? Because the guide support is poor and you have really terrible time doing PCI, because every time your wire would back up, your balloons would not go through, the stents would not go through. The things you can do here are buddy wire, anchor balloon, deep throating the guide wire with balloon or stent support. You can take the balloon, stent somewhere down in the coronary arteries, and using the shaft of the balloon or the stent as a thick guide wire, you can actually manipulate the catheter deep into the coronary ostium. And you should always use short stent and stents with easy deliverability if you want to have ease in doing these procedures. Sometimes they can be really, really challenging, and you end up wasting a lot of time, a lot of contrast, and trying to expose yourself to a lot of radiation also. Now, this is the case again, demonstrating the problems that you encounter with support. You see, you could barely engage the slit-like ostium with the implants, and in a non-selective manner, you manage to cross it. You manage to enter the wire into the. You manage to make the wire enter the lumen and the coronary arteries, but the support is not there. It kept on throwing back. I just take, if you allow me, sir, I carry on. Yeah. So the first thing I told you was a buddy wire. You take a buddy wire, you cross it, and then you have excellent support. But sometimes with buddy wire, it also does not work. So what you do is the stent. You see, the stent is not going in every time the catheter is backing up. If you note it here, so what you do is take the catheter a bit deep down, then rotate your guide and push it inside using the shaft of the stent balloon as the thick guiding catheter, and then you are able to do these procedures. Coming to the last of our discussion, that is the left coronary artery from right sinus. Whereas circumflex and RC are very disciplined, left coronary artery from right sinus is notorious. It can take any course. It can go interarterial, it can go anterior to the pulmonary artery, it can go retro-aortic, and it can take a myocardial course through the septum. How do you identify it? Which is the best angiographic view? Even if I am confused now, you are not. The best view is RAO view, and you see here in the RAO view. You see here in the, we'll come to the RAO view again, but this is what you see is the anomalous left coronary arteries coming, going all the way here from the right sinus coming into the interventricular groove. And how you identify the course, there's a still image here. So our example is here. So what you have to understand is, and this is something very important, I want you all to pay attention, if the course of the LAD, anomalous LAD from the right sinus makes a dome in the right superior quadrant, then it's anterior to the pulmonary artery. So our example is going left coronary artery from right sinus going anterior to the pulmonary artery. Just at when it is anterior to the pulmonary artery, there is this critical lesion here that we will show in the later slides. But anterior to the pulmonary artery will make a dome shape in the right upper quadrant. If it makes a U in the left lower quadrant of your frame, then it's a retro-aortic course. It goes retro-aorta and then it comes back, comes down again. You can see it here. If it makes a U in the right lower quadrant like this and then takes a bend up and comes down, it is the septal or the myocardial course. But the most difficult artery to identify here is the interarterial course, where it will take a sharp bend here, then it will go end on between the pulmonary artery and the aorta, and this end on vessel will appear thick and it will appear like an I sign that is classically described. Then it will take a sharp bend and come into the, it's not like a dome shape, it's a sharp bend and it comes into the interventricular groove, and that's why you identify the interarterial course of the left coronary arteries. Remember, in contrast to right coronary artery, where the interarterial course is usually benign, interarterial course of anomalous LAD is always malignant and should be surgically treated even in the absence of symptoms. So, implants is not always the guide, it's a myth. You see here, we were using implants to cross, but there's no way the balloon would not cross the lesion, the implants would back up. It's coming from the right side, so the best thing to do is engage it from the right coronary artery catheter, and then you could easily complete the procedure. So choose the guide which helps you rather than following some strict textbook rules. We can have single coronary arteries from right sinus, where from right sinus and from left sinus, when there's a giant ostia from which both the RCA and the left system are coming. In this example, you had critical lesions in both RCA and LAD that were treated significantly well. So for the sake of time, I would end here, and I want to leave you all with these messages that anomalous circumflex from right sinus is always retro-aortic in course. Anomalous RCA from left sinus would almost always be interarterial in course. Interarterial course is always malignant with LAD, rarely malignant with RCA. Most important angiographic view for anomalous coronary artery origin and course is the RAO view, and the two biggest challenges we have to face during PCI are guide engagement and guide support, but with few tips and tricks and play of hands and changing of adequate guide wire, guiding catheters easily and manipulating your guide catheters well, you can overcome these challenges. I'm sorry for overstep the time. Thank you, sir.
Rishi, thanks. Very complex topic, but you have elaborated it very nicely. As I can summarize, the most important anomaly which we are concerned is the interarterial course, because as you rightly said, the LAD is malignant, but RCA can also be. So now these days, with the availability of CT angio, the things are quite simpler. Otherwise, as you explained, we used to go by these signs. Can simply putting a catheter in pulmonary artery helps the swan gain?
Yes, but I mean, see, we know that RCA would always be interarterial. The question will always be only with the left coronary artery origin. And in RAO view, see, retro-aortic LAD is extremely, extremely, extremely rare. So, you know, whether it's coming from the septal or whether it's going to anterior to pulmonary artery can be easily picked up, I feel, in the angiogram itself. But we can be sure if you put a pulmonary catheter in, then probably we will be much
these
sure.
were older days when the CT was not available. This is what we used to do.
Yeah.
And number two tricks which we used to do was, as you explained, one was with putting the boiling water.
Yeah.
Other is use the hair dryer.
Hair dryer.
You know,
Hair dryer.
and then make the shapes.
Hair dryer.
Because we read lot of catheters in the textbook.
Right.
But there will be very hardly labs except for very big centers,
Right.
which catheters are available except for the Judkins and Emplas. So I don't know whether what catheter, special catheter is in your lab being so active is available.
No, it's we use only implants, and rarely once every, maybe I would say 2 to 3 years we would require to bend the catheters like that.
So there is a question we have from the audience. Dr. Yugesh has a question. No, Dr. Swapnil. He has a question. Grand Slam a better choice for body wire?
Better?
Is Grand Slam? I'll just come to you,
Oh, of course,
Yadav.
any extra support wire. I mean, Grand Slam is, you have balanced heavyweight, you have all stars. Any heavy duty wire would be coronary wire with more weight in its body would be good for body wire. But remember, sometimes your guiding is such precariously placed at the ostia that even taking a heavy guide wire may sometimes push it off. So, I mean, I always find that putting wires as much as possible, taking a hydrophilic wire because they are smooth to go, and even if they encounter a lesion, you can easily slip them through, and then take a balloon, and the shaft of the balloon and wire would become a very strong body in itself, and on that shaft of the wire and shaft of the balloon and wire, you can manipulate the guide deep inside the coronary artery.
Another question is from Dr. Balaji Sundareshan. He says, can we use Ikari for anomalous origin of RCA from the left sinus? Ikari catheter.
Ikari is good for, if you want to use one single catheter for both left and right side. But Ikari is never a good support guiding catheter. It's just a, more a fancified variation of your Tiger catheter. I don't, my personal opinion, Ikari would not be a good choice for anomalous coronary.
What do you think, the as most of us now have converted to radial instead of femoral, when you land up with anomalous coronary arteries, so is femoral a better approach?
I feel that if we have started radial, then there is no reason to switch, because uh, for most radial interventionists, it should not be, really challenging case. But in early stages, or if you have a diagnosed anomalous coronary artery and you are deciding the choice of, your access before, then femoral would make your life much easier than radial.
Can I have comment?
So please.
Yeah, you can use guide extension for the support. Nowadays with the guide extension, it can be done very easily. Anomalous, both the RCA from the left sinus or from the high anterior origin,
Correct.
all can be
Yeah,
corrected.
first we have to get the wire in. Once you get
Yeah.
the wire in,
Only then guide,
then
yeah.
their problems are little lesser. You can use a poor man's a balloon also and hook the.
Yeah, guide extension would always be, an option. But as I said again, it is sometimes hanging so precariously that the weight of the guide extension itself, pushes us down. So that's again, but guide extension is always an option. Yeah.
Uh, then another, how the pulmonary pressure is say 25, aortic pressure is 100 during
Yep.
systole,
Yep.
and diastolic say 70 and 10. How it will compress the right coronary artery from left coronary sinus between the two? How it will compress?
I think it's a very, very
cannot, hemodynamically it cannot compress.
I think it's a very, very relevant question. The question is that even in the interarterial course, pulmonary artery pressure would never be high enough to compress the coronary arteries. So, as I said, uh, the rare cases where we have seen pulmonary artery pressures, compressing the coronary arteries like that has been the cases of pulmonary arterial hypertension and Eisenmenger syndrome, those situations. Otherwise, it is one of the contributing factors, but more common etiologies are slit like, it's not a funnel shaped ostium, slit like ostium, the ostium taking a very sharp bend, proximal portion taking a very sharp bend, the 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 portion of the artery between the pulmonary artery and the aorta many a times have a, intermyocardial cause, that is the bridging of the artery, and with the bridging of the artery sometimes we have seen associated CAD also. So these are all the reasons that make the artery, kind of susceptible to being a malignant artery.
From the LAD, mid part of the.
Oh yes, RCA does, not LAD, left main. RCA comes out from the proximal segment of left main, and that is actually the most challenging anatomy, because you end up missing it, and then it is very, very difficult to engage and do, because you simultaneously you have a left main which is being played, and you can't mess around too much in that area. So I think RCA coming out from just the proximal segment of left main is one of the most challenging angioplasties.
The last question, which is from our audience, international audience, Dr. Leverov again. A STEMI patient, anomalous LED with arterial course detected. Can PCI be done? Is stent compressible is a worry, or CABG is a usually asked question, that in anomalous LED can you stent it and hope that this doesn't compress?
I mean, that would be a very, very unfortunate scenario for the patient to, have an interarterial course of LED and have a myocardial infarction on top of that. If we have taken the patient on table, there would be no clear answers based upon the data, but my preference would be like, get ahead with the primary angioplasty first and then, reevaluate ischemia later on. Of course.
But people have tried the, not in STEMI situation, otherwise stent, but failed, I think. So if you have to do, I think surgery is the better option. If you
Surgery
have
would,
anomalous.
so if it's not a totally occluded artery, there are stories
No,
of
suppose there is no occlusion. You
no
just
occlusion,
detect.
no occlusion, then wait and send for surgery.
Huh?
Send for surgery.
Because many people have tried that in a case reports, that just put a stent hoping that stent will
No, the
not
stent.
compress.
There have been case reports in Eisenmenger syndrome where a stent and a metallic stents have been put. Non-drug-eluting older generation stents have been put, but all ultimately end up being crushed in PAH.
Okay, so I'll just take one more because it's from Myanmar. Could you explain the shaping of the tip of AL catheter again? You explained, I think, with the hot water. So this is what he wants to know.
Yeah. So I do not know if I can take it, but you have I do not know if it's an international question. If they can see me or not, I don't know.
No, they can
They
see
can
you.
see you.
They can
see
see you.
us.
Because this is
So if the normal course of your guiding catheter distal is like this, uh, it's in one plane. You have to change the plane of the tip that points forward. So it would be 90 degrees off plane. And normally you'll just bend it and maybe kink it, but you can't bend it. So what you actually should do is put a guide wire or put a coronary wire introductory sheath, that needle into the distal end of the guiding catheter in the lumen, then put it in hot boiling water and twist that metal and guiding catheter forward 90 degrees so that it points forward, and then put it in cold water so that it retains its shape. So hair dryers or boiling water for making it malleable, cold water for making it stay that way. You can take out the wire and the needle, and the catheter will retain that shape for some time. So you have to quickly engage it because it will again lose its shape when you take it down in the coronary arteries and spend more time with it.
Okay, thank you,
Thank you.
Rishi,
Thank you
for
so
the
much.
excellent lecture. I
Thank you,
think
sir.
we learned lots of tips. I think.
Thank you
Thank
so
you.
much.
Thanks a lot.